It is. Well, welcome everyone. My name is John Martin, Dr. John Martin. I'm the Chief Medical Officer Emeritus of Butterfly Network, and I'm happy to bring you our latest installment of the POCUS Power Hour. We do these webinars, and literally we started these during COVID in a way to actually share information about the development of point-of-care ultrasound in the clinical practice of medicine. We cover a wide variety of topics and with very important guests along the way to share their experience and how we transform medicine with the delivery of ultrasound at the bedside. Tonight is no exception. I think what's critically important as we've seen the evolution of ultrasound used in the various clinical settings, it takes leaders actually to move the ball forward. We tend to be stubborn people in medicine. We don't like to change what we do very easily, but it takes people to nudge us, shove us, or lead us in the new direction. And tonight, we're very fortunate to have two key leaders that are leading the way on medical education with ultrasound. I think as we look toward the future, it really all begins with our students and our residents because they are the future of healthcare. And I think I love to teach, and I think these guys do as well. The eager young minds who are willing to learn with everything we have. It's a heck of a lot easier to teach a young mind something new than an old grizzly veteran to change them from what they are doing. And so I think this is how the real evolution is going to occur. We're really fortunate tonight to have Dr. Joshua Cox and Dr. Robert Arntz, two clinicians who are also leaders in the field from KCU, Kansas City University, and I'm going to let them describe themselves as well as the university to give you a perspective. I will tell you this is an outstanding institution who has an incredible program, and there's a lot to learn from these two because I can guarantee you that I have, despite how much exposure I have from ultrasound. And so I think we're really lucky to have these leaders share with us their experience of how they brought point-of-care ultrasound into medical education in their institution, what they learned, how they did it, what they plan going forward, and what they can share with you. So, gentlemen, Mr. Provost, I will start with you. You can start off. Can you tell us a little bit about the university itself and then your role in the university and how you came to be there?
Yeah, thanks, Dr. Martin. So, good evening. I'm Dr. Joshua Cox. I'm a family physician and have the privilege of serving as the Executive Dean of the College of Osteopathic Medicine here at KCU and the Interim Provost. And Kansas City University College of Osteopathic Medicine is the fourth largest medical school in the country. We have about, per class, we have about 430 or so medical students across two campuses. And the reason I mention that is that that was an important piece as we developed our point-of-care ultrasound, just the sheer size of our student body. And again, we'll get into maybe some of those details as the hour goes on. And I've been with the university, so I'm an alumnus of KCU, but I've been with the university as an employee now for almost 20 years. I only mention that because I do believe in what we do, or else I wouldn't have come back. And if I did come back, I certainly wouldn't have stayed this long. I did come on as an assistant professor and have had a number of different jobs and responsibilities over the last couple of decades, and really proud to have partnered with Dr. Arntz and rolled out our point-of-care ultrasound curriculum as it is now, and hopefully as it will become in the future. So, Dr. Arntz, do you want to introduce yourself?
Sure. So I'm Bob Arntz. I'm the Director of Clinical Integration at KCU. I'm an ER doctor by training. I practiced emergency medicine for the last 31 years. I've been attending an emergency medicine residency, and I started at KCU about 8 years ago. I've been using point-of-care ultrasound in my practice since the mid-90s. Initially with fast scans, and then of course it expanded with line placement and rush protocol and all these types of things. So that's my background and kind of how I became interested in point-of-care ultrasound.
So clearly you guys are in the thick of it. How did it start there? What was point-of-care ultrasound there, Dr. Arntz, when you got there, or did you bring it to the university?
So when I initially came, we didn't have a point-of-care ultrasound program, but there was interest. And part of the I think struggle for every institution is if you don't have a place, if you don't have something in place, how do you start it? And so we started initially with integration into our ECOS courses, which are the courses where our students learn clinical skills, history, physical exam, and so we initially bought enough probes to be able to adequately have labs on each campus, and I think we bought roughly 10 probes for each campus. And that's how we got started. I think one of the decisions everybody has to make as an institution is, what do you go with? Like when I'm in the ER, I have a $65,000 machine that's really, really nice. But if you're trying to teach people how to do ultrasound, that's a procedural skill and it requires the ability to drive the machine. You have to have access to the probe. And so really the handheld devices are really, in my opinion, the way to go when you're trying to teach students how to perform point-of-care ultrasound.
So when you got to the point where you had to buy 10 probes, and we'll talk a little bit about kind of the one-to-many versus one-to-one model, and what the value is. How did you get access to money to do that? Where did that come from? And how much did our dean here play a role in deciding here's the money to fund to do this?
Do you want to address that, Josh,
Yeah,
or?
sure. I can jump in on that one. So as you mentioned, we have had some phases and we'll get into that tonight, but the initial phase, uh, Bob was, well, let me back up a minute. If I have an initiative that's my idea, that's one thing. But if I have a faculty champion driving an initiative, that's a whole nother thing, because that way I can justify the expense. If I'm the only one that's inspired to do a program like this and I buy 20 probes, 10 per campus, and then I don't have a champion driving the implementation of the program, they just sit there and collect dust. And so having that champion was kind of the first critical step and part of what I used for justification for budget. Because he had done, what he didn't mention is he had already had kind of some student interest group activity, he and a couple of other of our colleagues. And so we had a small cohort of students very eager for this skill set. And they were working alongside with Dr. Arntz and a couple other faculty. And so we had some data and evidence to support the interest. We had some data and evidence to support. I have faculty champions who will implement it almost immediately within the curriculum. And so then it just came down to the actual bottom line, the money piece. To buy 20 units is a lot easier of a sell and easier to manipulate resources than 450 units, for example. And a couple of ways we can do it is shift, because we know that a budget is a budget. So we have X number of dollars to spend for the next academic year. That piece is a given. But what we can move around is line items, right? And so some of the larger line items, maybe there's some flex there so that we want to prioritize buying 20 machines and ultimately 450 machines. And so as we reprioritize some of those items and have the justification and or the faculty resources available to us, we can then also use that as a fundraising or philanthropic opportunity. We have alumni, for example, who have become radiologists, who have become emergency room physicians or pain management specialists that really believe in the importance of adding imaging to clinical practice. And so there's opportunities to flat out support an initiative such as our point of care ultrasound curriculum. And then there's opportunities to have like a Dean's Excellence Fund is something we have, which is a discretionary fund that I have. So both the philanthropic dollars and this discretionary fund are above and beyond that operational budget line. So in addition to reallocation and prioritization, I then have some flexibility because we have this initiative and a lot of oomph behind it. Therefore, our donors are more likely to contribute to those accessory funds.
So you've kind of covered on it. I like to think about this as instead of a three-legged stool, a four-legged stool, and that starts with you need faculty to teach. The bottom line is you got to have somebody that's willing to champion it, and obviously the more of Dr. Arntz's to have, the better, but you need at least one who's going to be the champion and say, I'm going to get people. And I think one of those points is you're teaching down to the students, if you will, but you're also teaching across and up to your colleagues because you need help with this. You got 450 students. You got a lot of energy, Dr. Arntz, but I doubt if you got enough to teach 450 people constantly. So I think one of those is faculty. The second you mentioned is student interest. Now, I think of all of the things, that's the easiest because students talk to each other around the country. They know they want to learn this, they know that's where it's going. So they want to come out of their medical school education having that skill set because it'll make their residency a lot easier no matter which one it is because they need that. So that's the second. The third, which you bring to the table, is you need C-suite support. Somebody up there at the tower who makes decisions got to say, you know what, I believe in this. I think this is the way of the future and support it. And you obviously played a key role. And the final piece of the puzzle is money. And I think as people think about building programs, they should think about all four of those and structure it. The second thing that you guys talked about a little bit, which I think is really important, is when you get started, there's a lot of questions we get asked. Where should you start? Is it the first year and they teach them what anatomy and all that other stuff that ultrasound should be? Should you wait till the clinical year to be part of it? Should it be a club or should it be part of the curriculum? How did you guys make that kind of decision at your institution? And is it the same now as it was, or have you evolved into a different model?
Yeah, I'd be happy to address that. So initially, um, the way things worked, I was fairly certain that we needed to go towards teaching point of care ultrasound, but I didn't know really what would be the best avenue to do that. I knew I needed a handheld probe because I had to have probes in the students' hands. And so actually myself and one of the other doctors, another ER doctor, we bought our own probes and I used them in clinical practice, but I also brought them for the students to use in their clubs. And immediately, once they started using them in their clubs and they saw the utility and really the ease of uptake, I mean, for old dogs like us, uh, learning how to use point of care ultrasound is a little bit more difficult, but this generation, they're tech savvy. And so they just take right off. The learning curve is very, very quick for them. And so once we got them in the clubs and the students saw what they could do with a handheld probe, then that was kind of the wellspring. And so then you get all this student interest. Students are asking for it. Then it's how do you integrate it? And we felt it best to put it in our courses where we're teaching clinical physical diagnosis and history, and that worked nicely. And then what happened? There was the opportunity to enroll in electives. So I talked to Josh about it, and really what we were waiting on, to be honest with you, we needed the AI. Okay. And the reason is, in my opinion, to learn a procedural skill, the student has to have ample opportunity to practice it. So you need access to probes. But then the other thing is you need real-time feedback, like somebody looking over your shoulder, if you will. That's the liver you're looking at, that's gallbladder you're looking at. Oh, if you do this, you can get a better scan. And so what happened when you guys came out, when Butterfly came out with their ScanLab, the AI, that took the place of that over-the-shoulder feedback that had to be there. And so it enabled us to offer these electives to a large number of students. And the students voted with their time, which is precious, and also with their money. Initially, when we started the electives, we had 350 students enroll. And this was across all classes,
Wow.
first years, second years, third years, and fourth years. And initially, they basically individually ate the cost of the probes because it was an elective and didn't roll into the budget. And so that's how things got started. And then after we saw the tremendous success with that, it became apparent that we needed to move forward. And now we're in a one-to-one model. So that's kind of how things evolved.
I would just add a little bit. So Dr. Arntz mentioned kind of enrolling in electives, but what he failed to describe was the fact that he designed said electives, created them, pushed them through our curriculum committee, and taught them. And so, yes, we also administratively enrolled the students in it. But while these 350 students were taking his 100, 200, 300, and 400 elective classes, and they could advance at whatever phase or rapidity or speed they were capable of doing based on where they were in their training, the entire cohort was still on campus for first and second year using those 20 or between 20 and 30 units that we had by then in those clinical skills courses. So it really went from that kind of interest group student club level with a handful of docs on both campuses and their own probes to several university-owned probes and every student getting at least some integration labs led by Dr. Arntz and a couple of colleagues, to then that continued while he rolled out these electives. So we had kind of parallel paths. Everybody gets the core introductory POCUS training, but then those that with that interest in the ability to and the resources to get the probes, then enrolled in those elective courses. And because of that overwhelming response and enrollment in those courses, that's what I was able to use as my data and evidence when we get back to that budget cycle to go from 4 to 20 to 30 units to 450 units as far as, budget, both in the prioritization, reallocation of funds, but then also in that philanthropic and Dean's Excellence Fund that we mentioned earlier. So that really kind of helped me, that sequence and stepwise approach Dr. Arntz took. It really helped with the justification piece of budget. If you go from 0 to 450 and don't have a champion, it's a failure waiting to happen, in my opinion. So, I'm not saying our approach was the best. I'm saying it was the approach that worked out for us. And it, as you can see, as Dr. Arntz kind of articulated, it was over a few years period of time. By the time we went from him and a couple of colleagues with the student interest group and then in the ER shifts to now the one-on-one where our entire first year cohort came to class, and during orientation, they received not only their iPad, but they got their probes as well, every single student.
So the real question that I have in this situation, and I got a bunch of them, but you guys have proven this is effective. Tell me, and I'm jumping a little bit ahead, but I'll come backwards. How much better are your students leaving now than they were? And can you then put some kind of objective measure on that? So you've taken this journey, you've gotten to there, and I guess part of the question, and I'll wear two different hats, one of which is I'm such a firm believer that people should be doing this. I always I sometimes know how important pilots are and early stuff is, but if you've got the horses in the stable, you don't have to redo this experiment. You guys have proven that it works and it's there. Does everybody really need to start small and grow if they've got people there, or can they jump into the deep end of the pool because we know swimming there is safe, effective, and makes you better? How important is it to start small and grow versus if you've got the right people to go big to start with? What would you say now once you've learned? I understand why you had to. It made complete sense, but you've proven now that it really makes a difference. So I want to know what's the difference in your students that you're graduating now versus then, and what advice would you give to people to say, should I go small or go big?
And
So I'll take the first, I can
Yeah.
take the first piece of that. So in terms of how our students are doing, so one of the challenges in my opinion, in medical education right now is it becomes very difficult for a student to distinguish themselves. Most things are pass fail now, whether that be coursework or boards. And so really where students need to shine is on audition rotations. And, so what's a third year medical student from MU versus one from KU versus one from KCU? And so when you're a residency director and you're looking, it's like, how do they perform while they're on clinical rotation with me? And our students, they really do well with point of care ultrasound. Many times they're as good or better than some of the residents, and they're generally better than most of the peers that they're competing with for those residency slots. I've had multiple students give me feedback about, hey, I got off a residency slot because of my point of care ultrasound skills, et cetera. And if you're looking for objective data, we're getting some data together, and we're going to publish a paper pretty quickly. But I can tell you that with the first series of electives offered, we had the 350 students. They submitted a total of 14,000 plus scans, which were reviewed by ultrasonographers at Butterfly, and they were graded based on the ASEP guidelines for quality. And the average score was 3.68, and anything above a 3 is considered clinically actionable. So my students are not only, anecdotally telling me about their success, but there's objective data that shows it, and also their time to scan. It drops significantly with the more scans they did, which is not surprising. But there's some objective data there that shows that yes, medical students can perform scans that are of the quality that you could make a medical clinical decision off of, and they're doing it in a timely fashion. So pretty compelling data.
So here's a question for you, and maybe it is a fair question or one that maybe not fair, but is there a way to measure how your students come out, got better residency programs or their first choice versus second or third based on that? I know that it's kind of a crazy question, but it's one to
It,
actually say, okay, it really helped and I got to go where I wanted to go because I had this skill?
It's a great question, and actually, we've got right in our IRB right now a project proposal to do a survey of all the people that have been involved with their point-of-care ultrasound and ask them those very things. Did this help you with your core rotations? Do you feel like you got a better evaluation because of it? And also on addition rotations, did you feel like that helped you get the residency you want? Those things are a little bit difficult to get to be honest with you. I mean, endpoint data for, did I match where I wanted to match? Did I get the residency I wanted to get? That's tricky, but, we're going to try to get at it.
Yeah, I think controlling for some of the variables is going to be difficult, but we are looking at it, like Dr. Arntz said. And the other thing is we only have X number of students thus far who have completed this series of electives, but here in a couple more years, we're going to have an entire cohort that has completed the entire curriculum. And so that data set is going to be tremendously larger. And so I would say stay tuned on that. I'll go back to one of your earlier questions about going big. I think there has to be a few pieces in place which weren't for us as we mentioned, and that's the faculty buy-in and expertise, if you will. We had a handful of POCUS experts, but a very large student cohort. So that just a numbers game and faculty training. And as Dr. Arntz pointed out, the AI has really helped us kind of level set with that piece of it. The curricular component. We didn't have, when we first rolled this out, a actual longitudinal curriculum, whether it was integrated into clinical skills labs or a freestanding elective or an entire cohort-wide course. We didn't have any of that in place, and so we weren't ready at that level. And then finally, the funds piece, which I've referenced a couple of times. And so it took us sequentially to get all of those together. If those that learn of our experiences and are able to maybe push past some of the steps that we had to go through to get to where we are, if they address their faculty needs, they address their curricular needs and the resource of budgets and funding for the machines, yeah, I mean, going large would have been great. And Dr. Arntz pressed early on to do a one-to-one, and we had a couple of meetings and we stepped back and we took it in a pace that made sense for us. But there was definitely a desire to get to the one-to-one faster than we did. And we were able to get past those rate limiting steps and ultimately get there. But there are probably plenty of institutions that are capable of going to the one-to-one in a more, let's just say, timely fashion, / straight away, if you will.
So and I want to encourage the audience to ask questions because you probably got a lot better ones than I do. And so I'm going to pop into those. But I'm going to come back to a couple of things because I really want to get to Arntz. You have a 100, 200, 300, 400 kind of level courses. I'd like very much for you to share what that looks like. But a couple of the questions that are out there, and we can kind of put them together. The first question was, looking back on your journey to implement it, what would you say was the most significant challenge and how'd you overcome them? And then the second one, which is probably with that, is that how'd you bring the faculty on board, especially those that may not have had any ultrasound experience? Had to train the old guys while you're training the new guys, and then we'll get to some more questions.
Yeah, so I think the biggest piece for me, we recognized we came to a point where institutionally senior leadership recognized the need to teach point-of-care ultrasound, and as faculty we did too. The problem was in the most common barrier. So if you look across the board at point-of-care ultrasound, most medical schools are teaching it, but if you dig further, most medical schools are finding difficulty implementing it. Okay, and the biggest barrier to implementation is enough faculty trained in point-of-care ultrasound. Okay, and so really we had gotten to a point where we could go no further until the AI came. And once the AI came, it provided the real-time feedback to every student, regardless of when they were scanning, where they could be scanning at 10 o'clock at night, completely away from me, and still get feedback on the quality of their scan, information on depth and gain, the structures that they were looking at. And so that really, the AI basically broke through a barrier for us and made it make sense to offer, a series of electives and progress to a one-to-one model.
Yeah, I probably should pause for a moment. You know, what Dr. Arntz is referring to is something Butterfly released called ScanLab, and it's an education-only tool. So it's a separate app, but one's free if you have the subscription. And what it does is, first of all, it gives you some instructions on how to scan, how to hold the probe, where do you position it, what are you looking at. It gives you anatomic references, actually, so you know what the image should look like if you get it right. It actually then, while you're scanning, it gives you real-time feedback on the quality of the image that you're getting and the moves you make. Does it make it better or worse? And actually does automatic anatomic labeling so you actually know what you're looking at when you get a good enough image. It's been an incredibly powerful tool to actually help you get better faster. And you know, the goal we have here at Butterfly is to expand the number of applications it's with. It's with heart, lung, fast exam now, and now aorta, and we'll continue to expand that. But I agree. It's a little bit like it's a Butterfly tutor over your shoulder, helping you along the way, and allows you to get better faster and understand what those moves are that makes. And so I think it's become an incredible addition to Butterfly, and I'm really excited that we did that. How'd you
I,
get the senior faculty? Oh, go ahead, Dr. Cox.
I would just add that that piece or that feature actually can help with some of the hesitation on faculty members' part too, because they then can establish more comfort level, not in front of a student or not in front of Dr. Arntz in the lab, right? They can work on the side on their own and master their own skill so that they can be a facilitator of one of the integrated clinical skills labs. And so then that helps you with your table training for live labs. And then the students and faculty can then on the side get the hands and the scans at their own pace, at their own speed. And then the more you do, the old cliche of practice makes perfect, that really does apply here. Without scanning, you're not going to get good at scanning. And this tool just allows you to do that. And so that kind of ties to that second question that you asked. And the first one about, a big challenge. I think one challenge for other institutions could be identifying a champion. For me, it happened in the best order where the champion brought a project and initiative forward as opposed to me having an initiative and identifying or begging someone to serve as a champion. That really did help facilitate things there. And then, of course, a rate limiting step that we've addressed a couple of times is just that of budget and funds. To buy 450 units, no matter what product you go with, is a very significant investment, and needs to be justified and done right.
I think kind of the two-edged sword, and all educators will say this, and that is one of the greatest joys is to have a student develop skills and you feel good about what they've learned. The flip side of it is when they get better at it than you are, it's a little bit frustrating, and you don't necessarily like to see that, but you know quietly inside that's fantastic. And I think this is one of those areas where they pick this stuff up quickly, much faster than we do. And I think, we talked a little bit about this beforehand, and I think it's worth mentioning now, and then I'll get to another question, and that is we're old school guys. I'll say this, and we learned a lot about physical diagnosis, about how it matters, understanding, the different signs that you can look at, what different things you see by physical examination, to actually know what to do with the stethoscope. It's not just a prop on a television commercial. It's actually a valuable tool that you can use, except for my friends, the orthopedic surgeons. No, I'm just kidding. I'm just kidding. We always have to have fun with those guys, right? But at the bottom line is, how do you complement the ultrasound skills that you're developing with your physical diagnosis, and how do you build that into the education process so students still value both and don't just lean on technology?
Yeah, so I see the use of the point-of-care ultrasound diagnostically almost as an extension of the physical exam. And so in many ways, I feel like it makes people better at physical exam. It's when you're, for example, if you're trying to feel a liver, and you're not sure where it is, and you can put the ultrasound probe on the patient, or if you're a student, a person you're practicing on, and you can actually see the liver, that's a great thing. And so, in my practice, sometimes the physical exam helps augment my ultrasound exam, and sometimes my ultrasound exam improves my physical exam. So for example, we were sharing before we got on, one day I had an elderly lady, she was hypotensive. I was kind of scratching my head about it, throw the ultrasound on her, and she's got a big pericardial effusion. She ended up having a viral myocarditis. Well, all of a sudden I became the greatest diagnostician in the world. I mean, she had, muffled heart sounds, and she had elevated jugular venous distension and all these physical findings, that I promptly diagnosed it or wrote down on my chart. But the reality was I saw the effusion, and then the physical exam made sense to me. And so I think you can work both ways, but I don't see it as, there's an argument out there that, if they're dependent on tech, they're not going to be good at physical exam. I'm not buying that. I see this as an extension of the physical exam. If you had a better stethoscope, that'd be a great thing. And I just see this as almost like the stethoscope of the future, really.
I think continuing to roll it in and integrate it into our clinical skills labs is what has really helped hit that home, Dr. Arntz, and I agree with what you've said.
What do you think are the best avenues for your faculty to get skills? Are there places outside that you send them, or did you do all of your internal training?
I can take that if you want it, Josh, either one. So basically, there is a ton of free open access medical education out there. So if you want to look at abnormal scans, you want to see pericardial effusion, you want to see a positive fast, fluid in the Morrison's pouch, et cetera. There's a gajillion and one places you can go to look at that. In terms of hands-on, Josh mentioned it before. There's no substitute for practice. I mean, if you want to get good at hitting a baseball, you hit 1,000 baseballs. If you want to get good at point-of-care ultrasound, you do a lot of them. And the reason our students are good at it is because they do a lot of them. Okay, there's no magic to my curriculum. It's literally practice. And so our with the AI, our faculty can practice just like our students. And you mentioned before, John, there's no fun to teaching somebody that's better at a skill than you are. And so, there's a lot of impetus on our clinical faculty to learn point-of-care ultrasound. And with the AI, I've seen just increased interest with them. There's no lack of faculty. When I first started teaching point-of-care ultrasound, there was a little bit of trepidation about faculty to come in there and help. But now with the AI, they're happy to go in there and facilitate and look, and it's become kind of this grassroots, very collegial atmosphere where sometimes students will teach the professor, sometimes professors teach the students. We're all kind of learning together, and it's really synergistic.
So there's an interesting question, and I'm not sure exactly how to answer it even myself, but there was a question about cost savings out there.
Mhm.
Have you been able to kind of implement this kind of program? Obviously, it's education, but transitioning over into the clinical environment. Have you been able to demonstrate there's a cost effectiveness to this that kind of is helping both on the medical school side and the maybe graduate medical education that's
Oh, I think in
implemented?
terms of, well, in terms of patient care, for example, I can speak directly to that. So, in my practice a lot. So let's say you have a female that comes in with left lower quadrant pain. Okay, and that could be a kidney stone. It could be an ovarian cyst, something like that, or it could be some bowel thing. Okay, and you're trying to decide what scan am I going to order? Am I going to order a CT without contrast? Am I going to order a CT with contrast? Am I going to do the stone protocol? It's very easy for me to just throw my ultrasound on, look at the kidney. Is there any hydro there? Is there not? And I can swing down, take a look at the ovary, and then so it guides my selection of the appropriate exam to do. And so if you look at the hard data, point-of-care ultrasound actually it increases speed of definitive diagnosis, and it decreases a lot of cost of testing. And so many times we can do things like, take for example, I get, this is an anecdotal thing, but this is something that one of my students just sent me back the other day. So they had a gentleman who came in. He was referred to the surgery clinic from the ER with possible cholelithiasis. That was the presumptive diagnosis. This gentleman didn't seek medical care because he didn't have any insurance. He was concerned about the bill. my student in the clinic asked the attending, "Can I do an ultrasound of this gentleman?" And he said yes. And so lo and behold, my student diagnoses gallstones. You can see the gallstones right there. Okay, so they went ahead and scheduled this gentleman for surgery based on the point-of-care ultrasound done by my student without him having to forego a formal ultrasound of the gallbladder and a $3,000 bill for that. And so, and these are things I see time and time again.
I think it's going to make some people shudder, but I think all of us here would say, that's great. I don't need to actually, if I can see it, I got an image that shows it, that's fantastic. And I think this has been one of the big things for me that people forget. And that is, oh, they've got insurance. They forget there's a big old copay that's tacked onto that for a lot of people, a lot of people. And so where you can do cost-effective testing, it's incredibly important to be able to use it. And ultrasound becomes one of those things. And whether it's lung ultrasound, abdominal ultrasound, for a lot of these different things, there's a lot of tests that we order that you could certainly answer the question with ultrasounds, document it on the chart, save the image because you've got the system to do that, and actually not have to do a lot of charges for doing it. I think that's an incredibly important point. Um, is there a signal that you had along the way that you were there, that you've gained the traction that you needed to? Was there a spark or a moment that you said, this is it, we're on our way?
I'll tell you the thing that I guess the realization for me that we were getting there. So our curriculum, what we have students scan, is based on what's available for the ScanLab feedback. So we do heart, lung, and EFAS. But the thing that told me, yeah, we're there, I all of a sudden had students that we'd never trained how to do a gallbladder, but because of the skills that they learned doing heart, lung, and EFAS, they're doing biliary exams. They're doing well OB exams. They're looking at carotids. They're doing all these other things. And so, in my mind as an educator, it's one thing if they can do what I ask them to do. It's another if they can take the skills that they've learned and apply them in doing something completely foreign to what I've asked them to do and do that well. So my students are comfortable enough that they can use their ultrasound skills and perform a scan that they've not had formal training to do and do it pretty well. So in my mind, that was kind of like, yeah, that's a nod, like we're getting there.
So have you taken your program, and I guess this may be for you, Dr. Cox, and now use this as an advantage to attract the best students to say, come to our school, and here's why, because we have this program. Has that worked to your advantage and as a competitive value proposition of your school?
Yeah, so the answer is yes, and I'll elaborate just a little bit. So even before we did the one-to-one model, we had several hundred students enrolled in the electives, and so it was not difficult to get buy-in from the student body. I think Dr. Arntz mentioned that earlier, and they talk. And so we quickly learned that that is a recruitment tool, right? We know that there are a lot of medical school seats becoming available. They're developing allopathic and osteopathic institutions across the country. So there's a lot more seats available in medical schools. But we also know that there's fewer college graduates, and we know that the level of applicants overall to medical school in general is pretty flat. So if we got seats going up, seat and interest staying flat and or potentially declining based on college graduation, we know we have to set ourselves apart. And so we fairly quickly decided to promote this, not as necessarily a bragging right, but this is a skill set that you will acquire. It's an expectation. And the fact that you're going to be distributed a probe on orientation during orientation week we used it as a selling point to help set us apart along with other things. But the answer to your question is yes.
And so you get together with your brethren deans around the country. What kind of questions are they asking you? What kind of bragging rights are you sharing with them? How are those conversations going? And what would you suggest to any other dean that's listening and that's seen what you've done? Do you get a chance to share what you've done with them?
Yeah, of course. I think money is always a topic of conversation. And so I talked to them a little bit about my strategy of reorganization and prioritization within my operational budget. Right. If X dollars is what you have, X dollars is what you have. But I also talked to them about our approach with our university relations and philanthropy and alumni teams as far as getting some of those extra funds that I referenced earlier. And so those are some topics of discussion to address that piece of it. I also encourage them to remember that there's the undergraduate medical education to graduate medical education continuum. So what Dr. Arntz hasn't mentioned is that he also does ultrasound curriculum for several of the residency programs that we sponsor. So KCU does not own and operate our own residencies, and we don't own and operate our own hospital, but we have affiliate hospitals where our faculty see patients, and we have residency programs that we sponsor as an ACGME sponsor. And so I think that that's an important piece to help them recognize that continuum, because not only are we preparing our students to be better residents, we're preparing our residents to be better providers, cut down on overall healthcare costs and efficiency of the patients. And so actually it does help at the hospital level as well, not just at the medical school level. Bob, do you want to talk a little bit about how you've rolled it into resident education as well?
Right. So what has happened with a lot of the residencies, the ACGME, like for example, family practice now, there's a requirement of point-of-care ultrasound, training, and most of the residencies have some form of point-of-care ultrasound in them, like emergency medicine's heavy, anesthesia, obstetrics and stuff. But what's happened, the technology, if you will, has kind of leapfrogged where a lot of us old guard are. There's a lot of people out there that are running residencies that really don't have a lot of point-of-care ultrasound experience, but all of a sudden now they're saddled with a situation where, okay, we gotta have our residents up to speed in ultrasound. And so there's a couple of things that this is very attractive. What we've kind of created has been very attractive. So number one, how do you show competency? And that's a difficult thing, okay? But we can objectively, like for example, the way we have this set up, if a residency would choose to do so, they could have those. If they have a champion there that could grade the scans on their own, that'd be fine. But if they don't, there exists a process by which they could have your ultrasonographers take a look at them and give them grades. So that's a good thing. The other piece that our program, the way we've got it set up, because we have a lot of students that go to different sites for clinical rotations across the country, our didactic stuff is basically self-driven, and it's voice over PowerPoints, which are MP4s with associated formative quizzes. So that's the didactic piece, and then you've got the scanning piece where each student or resident develops their own portfolio of scans that are then objectively evaluated. And that's really where the money is right there. That's where they get good. It's the practice. So that's been attractive to a lot of residencies that really don't have maybe a champion per se in their residency or someone yet. Now, I think over time, what's going to happen is as this generation of doctors comes out, you're going to find people that are going to be integrated into those residencies that have point-of-care ultrasound capabilities. But for right now, this is a very attractive option to a lot of people.
And that really speaks to that kind of objective piece of competency-based education, both for medical school and resident levels.
So one of the things some of the others have used, and it's mentioned in the questions, have you used sonographers at all as educators in your program? I know other schools have done that as well.
We have not used sonographers in our program, but we definitely to provide instruction certainly wouldn't be opposed to that. That has just not come up for us. What we do use the sonographers for is overreads, and that's through Butterfly. But it's really nice to have professional ultrasonographers taking a look at these scans. And to be honest with you, I like the objectivity of it. One of the concerns I have, like if I were reading all the scans, number one, I couldn't because I'm not going to be able to read 14,000 scans, right? But let's say I'm a residency director at a program. How objective am I going to be about my residents and their ability to perform point-of-care ultrasound when I know that they need competency confirmed in point-of-care ultrasound to matriculate? And so I like the independent kind of objective review.
I think it's really hard not to know a student and to be as objective. I know we all try to as educators, but you can't help it. And I agree with you. How did you guys, when you only had a limited number of probes, how did you let students schedule using them when they didn't have their own? I mean, obviously, I'm a huge fan of take it home and practice, but before then, how did you actually manage that when you had 5,000 students and three probes? How did you guys do that?
Yeah, it was really tough. So the 10 probes, the way we had our labs structured, so the way it would work, there would be a didactic content that they would need to complete with formative quiz before they came to lab, and that was required. And then when they came to lab, they would be broken up into groups, typically 4 students per, and they would all share the probe. One would drive, and everybody else would watch, and then they would rotate who got to drive. That's not ideal, but it was the best thing we could do to get actually the probe in everybody's hand. And so that's how we started initially. And we also, when those probes weren't being used, and those probes were being used heavily because not only were they being used by our students, but also by some of our affiliated residencies. And so when those weren't being used by our students or our residents, there was the opportunity for students to check those out and practice on their own. So that's how we started initially.
We've had a number of questions from international people who are watching, and they're incredibly jealous, and they're very excited to see the same kind of programs over there. There's been a lot of compliments on your program. You've talked a little bit about different levels, 100, 200, 300, 400. Can you just briefly describe for people how you set that up so they get some feel of how you set up your curriculum?
Yeah, I'll give you the keys to the kingdom. So basically, when I felt the need to really put together a program, I did a lot of lit searching, and so my program is literally based on this. And what this is medical student core clinical ultrasound milestones. So this is an old article, but basically what this article did, it reached out to people that were educators in medical schools across the nation, both allopathic and I think it was just allopathic, but they asked them, what do you feel are essential skills? And they all reached a consensus on what they thought were consensus skills. And so that's kind of what I based our curriculum on. But so I have an introduction to point-of-care ultrasound lecture, okay? And in that lecture, it's basic stuff, like what is an ultrasound, hyperechoic, hypoechoic. We talked about artifacts. We talked about gain. We talked about how to adjust the probe and those types of things, and what kind of probes there are, and so very basic. And then we have a cardiac, and then we have pulmonary, and we have abdominal, and so each of those basically became its own lecture, and it was driven by kind of this consensus idea from all the educators that train people in point-of-care ultrasound, what they thought would be an appropriate medical school curriculum. Now, since I have developed my curriculum, there's been multiple other folks come out and say, "Hey, we think this is what we should do," or whatever. I know there's an interesting report where the radiologists all got together and wanted to throw their 2 cents in because they didn't want to miss the band on the point-of-care ultrasound craze, and so they've got what they feel is important. There's a lot of things out there that you could use now, but that's what I built the program off of, and so our program consists of kind of introductory stuff. Goes over the physics, goes over the knobology, how you set depth and gain and presets and stuff like that. Goes over the different types of probes. Then it covers echogenicity, covers the type of artifacts you'd see, and then specific anatomical scans. And we talk about like how to perform them. I use a lot of the butterfly videos on that. There's some excellent videos Butterfly put out about like how do I perform the scan, and then also integrated some pathology. Some of the pathology is stuff from my clinical practice, and other pathology is things that I found on free open access med-ed stuff to show pathology. But that's how our program's set up.
Have you found that there's from the beginning to end you've learned this? What did you learn from your students and teaching them that may be a skill or something that you didn't know before you started all this? Did getting into this process change you in any way? Change your practice of medicine in the emergency department? And I would since Dr. Cox, you still stick your nose in the middle of it as well. Is there anything that having done this made you different along the way?
So one of the things I think this has helped me with is when you give our students, this generation of learners, the tools and the instruction, sometimes we need to stay out of their way and let them do great things. And again, moving from the handful of probes, after Bob first rolled out the lab that he explained where you'd have four learners per probe, then there was a desire, oh, well, what about, after lab, can I check it out? And so we tried to establish a checkout process. Well, that requires an operations person to sign them in, sign them out, make sure they're charged. And so there's a lot of logistics behind that. But again, it's that eagerness. And so what I've learned is, yes, we have to equip them with the tools and guide them and mentor them and lead them in the right direction. But sometimes we need to get out of their way so that they can be their best selves and be the next generation of physicians.
Yeah, that's well said. I can tell you, there's two things for me. So in my practice of emergency medicine, I didn't do a lot of MSK. That's in my mind more, PM&R and primary care doing joint injections, stuff like that. But there's a tremendous interest with our students in MSK. So I'm better now at MSK because that was driven by the desire of the students to learn it. And so I had to bone up on it to stay ahead of them because, they're, hey, what is this? I'm like, I think it's the rotator cuff, and so I had to get out in front of them on it. And then the other thing that's happened for us, this point-of-care ultrasound curriculum and program we have, it had such a grassroots kind of evolution. So now a lot of my electives, I have point-of-care ultrasound docents that basically they're people that have gone through the program. They're in their POCUS 400 now, and they're coming back on their spare time and they're training the younger students. So when we have a lab that's an all-together lab, I don't even have to be there because the students in 400 come in and help the students that are in 100 get their scans and help them with probe placement and stuff. And what I found is students can learn from me pretty well, but they actually learn from each other really well. And there's not that anxiety of, oh, like Dr. Arntz is looking over my shoulder. It's, well, this guy's just a year ahead of me. And so it's been really fun to watch that.
I think that's such an incredible point. And I think, listen, let's look back to our own residency programs. I can tell you as a surgeon, I trained in the era where a lot of my training was from fellow residents, and it felt a whole lot different learning from them than it did when the attending was there, because all of our sphincter tones changed instantly when the attending walked in the room. There's no question about it. And it's I think that's an incredibly valuable point to bring out, that schools should take advantage of their students, the senior students that know how to do it, and let them be part of the process, because the flip side of that is you really know it if you can teach somebody how to do it. And I think that
See
that's
one, do one, teach one. Yep.
I think that that's a key part of this. There's Dr. Rhodes out there ask, how many scans do you have the students upload for your stuff each year or semester, and how much
Yeah.
does that go their grades?
Yeah, so one of our components of the program is each student develops their own portfolio, and that follows them through not only the curriculum we have, but beyond. Okay, and so in POCUS 100, they're required to do 3 heart, 3 lung, and 3 EFAST. Those have to be uploaded, evaluated by one of the ultrasonographers, and they have to achieve a score of 3 or higher for it to count. Okay, and then in POCUS 200, it's 5, 5, and 5, and in POCUS 300, it's 7, 7, and 7. But then we transition them in POCUS 300 out of ScanLab into the regular scanning app to get a sense of what it's like to put together a scan that would be codable and billable, in residency. And then finally in POCUS 400, that's more of a freestyle thing. That's so by the time they get through, and the reason I use those numbers, if you look at residency competency, like for ASAP for ER physicians, 25 scans is kind of considered ballpark for, if you've done 25 EFAST scans, you're probably okay at it, and so that was kind of the goal to get there. So that's kind of the way we loaded the scans. I backed off on some of them because candidly, it takes novice learners a lot of time to do those scans. And so, we peeled back the requirements for some of them. But our POCUS 400, that's a freestyle. So like, let's say I have somebody that wants to go into obstetrics. So they have to do 25 scans of any type. They could be heart, they could be lung, they could be EFAST, or they could be, let's say I'm going to be an ENT doctor and I want to scan thyroids. Okay, you could do that. Or, I want to be an obstetrical doctor and I want to scan uterus, ovaries, stuff like that. I could do that. Or maybe I want to focus on joint injections, want to go into PM&R, or maybe, do primary care and be real active. Then it's MSK. So they have the opportunity to build kind of what they want into their portfolio in that last elective.
How much of the versatility of the probe actually plays into how successful this has all been? And I mean, was that a big thing for you?
Yeah, it's a huge thing. So when I first started looking for probes, I really wanted something that you could do anything with. And so there's a couple of ways to do that. I mean, you could have a big, $65,000 machine that has different probes specifically for what you're doing, and you just toggle between the probes. Or you could have something like a butterfly where you're just changing frequencies essentially, and that allows you to do, like the probe is very versatile. So, I can do MSK, I can do heart, lung, EFAST, pretty much anything within the realm of what I want to look at, I can look at. The other thing that I found particularly interesting with the probes we use with Butterfly, they have bidirectional imaging. So like when I'm talking about needle driving, so let's say, if I'm sticking a needle in a vessel, most of the time I like the transverse view, okay? But I can hit the bidirectional plane, and I can also see that in longitudinal view and know that I haven't gone through the back wall of the vessel. I mean, and that's a classic, the classic thing. You go through, oh, I got through, and then you got to pull back, to put your central line in. So the bidirectional stuff on the butterflies is really handy. I can tell you, when I go and work in small hospitals that have limited ultrasound, like their ultrasonographers only there, Monday through Friday, 8 to 5, and that doesn't help me on the weekend at night or whatever, I just take my butterfly probe with me. Now, if I'm in the big house with the residency and the $65,000 machine, I'll use that. But if I'm at the bedside, if I respond to a code, I'll use my butterfly. Because I'm not going to wheel the big sucker down the hall, right?
How much has image quality played a role in that? I know you've seen the evolution of the handhelds get much better and better image quality as they've matured. How important is that in your education stuff?
Yeah, it's very important. I mean, so to a lesser degree in education, because as long as they can see the structures, there's like a quality line. If you can't identify structures, then it's of no use. But even with the IQ Plus, it was pretty good at being able to identify structures. I can look at parasternal long on a heart and see the anterior leaflet and posterior leaflet of mitral valve. I can identify all the aortic outflow tract, all that stuff with an IQ Plus. The IQ 3 is a lot better, in terms of the definition of image and stuff like that. These probes are not the equivalent of, say, a $65,000 machine, but they're pretty good. I mean, pretty close. And so $3,000, $4,000, $65,000, I can put this in my pocket. This won't fit in the elevator. I mean, it's, for me, I think, it's like, you guys mentioned beforehand, both Dr. Cox and Dr. Martin are former military. Well, it's kind of like, what mission are you needing here? And it's, I think, more than adequate for training. The thing that's the most important about training in my mind, you have to have the student get an opportunity to use the probe. It does no good for me to drive around a probe and tell them how to do it. They have to do it themselves. It's just like hitting a baseball, or, the more you do, the better you get. Part of it's muscle memory, part of it's spatial orientation, and part of it's, image identification.
So we've got how an hour blew by. Holy smokes. I guess from closing comments, two things. One of which is, what's the future look like at KCU? You know, what are you going to do going forward? Where's the next hurdle, the next mountain? I know you guys are always reaching for bigger and better. And then if you had some final words, each one of you say advice you would give to people of how to take this on and how to become like KCU. You guys are stars on what you do. Your students are actually glowing with what they're saying. What advice would you give to people to follow in your footsteps? So I'll give you both. What's the future, and what lasting words would you leave with people as we close this out tonight?
I'll
Well,
have
I take the future and you take how to
deal.
get there. So,
Yeah, deal.
so what I envision in the future for us, we're going to integrate more and more of this with just basic physical exam, and we're going to implement needle driving. That's one of the things that's going to require, that's more investment because you're going to have mannequins. And I can tell you, initially when I was looking at doing some needle driving, the mannequins that were out there were not of good enough quality really to even waste the money on buying them. That has rapidly changed, and there are some really nice mannequins out there that it looks pretty close to putting in, putting a probe in, needle-driven probe into or a probe-driven needle into a vessel, and so we're gonna implement that, and I think that's going to be the next big thing for us because regardless of what you do in medicine now, the world is over a wire. If you're an interventional radiologist, you're putting a needle in a vessel, you're fishing a wire through it, and then you're running your stuff over the top of it. If you're a surgeon, you're doing the same thing. If you're an anesthesiologist, you're doing the same thing. Crit care, ER, that's the way things are. And so to be able to, hit targets with a needle, with point-of-care ultrasound guidance, that's not only going to be where the future heads, I think that's going to be the standard of care. And if you don't do that, you're going to have to justify why you didn't. And so I want my students, when they come out, not only to be good diagnosticians, but also good with their hands in the ability to use point-of-care ultrasound to augment procedures. And so that's where we're headed next. The other thing we'll do as Butterfly rolls out more and more AI, we will add those things. So for example, we do heart, lung, and EFAS now, but they've just added aorta. Guess what we're adding? We're going to have aorta, So that's where I see things are going for us. And I'll leave it to Josh to tell you how to get there.
Yeah, I think just a couple of comments I would make is stay persistent, and in your persistence in exploring this, use the data and evidence that are available. I think everybody on this call knows that it's the right thing to do as far as training our students and residents in point-of-care ultrasound. So use that existing data and evidence to support that persistence as to why you need to make this investment. And then finally, collaborate and partnership are important. Collaboration and partnership. You don't have to recreate every wheel. There are opportunities to collaborate with other institutions, with industries such as Butterfly, with KCU, with Dr. Arntz. So take advantage of collaboration and partnership as you explore. Those would be my thoughts.
So you guys are open for people to contact you and to share your stuff and help them along. I think that would be fantastic. Well, listen, I think this has been great. We really covered the gamut of different things. You guys were very open, honest, and transparent about, where the struggles were, what you were able to accomplish, where your students are today. I think you serve as a great role model for others to follow. And I think if we can get every medical school in the country teaching ultrasound at the scope that you guys are, I think all of us can feel confident that the doctors of tomorrow are going to be better doctors because I think hands down, and maybe one of the biggest challenges that I find in all of this and in my journey being at Butterfly for the last 8 or 9 years, there's no question in my mind. The data certainly affirms it. You're a better doctor if you know how to do this. You just are. You perform better exams, you get more information, your patients get care better and faster. And I so think as educators, I want to congratulate both of you of making the future of medicine better and setting a great example for those across the country. And we really appreciate your partnership with us. And we look forward to actually continue to expanding and share the work that you've done forward. So thank you very much. Thank you everybody for attending. Please pass this along. This will be recorded. It is recorded, so you can share it with other people, watch it again. And we certainly welcome here at Butterfly any comments you make on how we can make the product better, our service to you better, and the education world of point of care ultrasound better. Have a good evening, everyone, and happy Halloween. Hope your costumes meet all of your great expectations and all your candy is sweet.